Good afternoon, and thank you for joining today's webinar. My name is Jackie Tompkins, and I work at the California Department of Public Health within our Substance and Addiction Prevention Branch, which houses the department's Overdose Prevention Initiative. Late last month, the department, alongside other state and local partners, learned about the LAGS Medical Center voluntarily closing 29 of its California locations. We acknowledge that such closures have real impacts to the community. In response, CDPH is pleased to have worked with our long-standing partners at CHOW, the Center for Innovation in Academic Detailing on Opioids, within the San Francisco Department of Public Health, to bring today's webinar focused on information sharing and discussing clinical tools for providers. CHOW has been serving California since 2016 and has recently expanded such efforts to serve the nation and remains a very active partner in CDPH and our state's overdose prevention initiative. Before we get started, I would also like to acknowledge and thank our Centers for Disease Control and Prevention for supporting our state's overdose prevention efforts, including today's webinar through our Overdose Data to Action Cooperative Agreement. Now I'm pleased to turn over today's webinar to CHOW, our CDPH partners, and today's presenters and subject matter experts. Rebecca?
Thank you so much, Jackie, for kicking us off. On behalf of our entire team here at the Center for Innovation in Academic Detailing on Opioids, I want to welcome you as well to today's webinar, What Do I Do with Inherited Patients on Opioids? We are extremely honored and humbled that so many of you registered to show up today and discuss a topic that's very motivating for our team here, how to take care of inherited patients while also taking care of ourselves as providers, dealing with the intricacies of chronic pain and opioid management. My name is Rebecca Martinez. I'm a family nurse practitioner and one of the clinician trainers on our team, and I will kick us off today. Next slide, please. So our agenda today will talk a little bit about who we are and what we do at CHOW. Thank you, Jackie, for your introduction to the context of the LAGS Pain Management Clinics closures, and we'll briefly discuss that as well. And then our content today is going to be twofold. We'll start with best practices in inheriting patients on opioids, followed by managing patients on buprenorphine. And then we plan to leave ample time at the end of our webinar for some Q&A. So please submit any questions into the Q&A. Next slide. Our vision at CHOW is to decrease opioid-related morbidity and mortality by promoting balanced approaches to opioid management. CHOW has been around actually since even the year 2014, when we did academic detailing projects on Naloxone throughout California. And we've expanded from working locally, where our office is based in San Francisco, to now working with the California Department of Public Health and the CDC on a national level through the Overdose Data to Action grant. We appreciate as well the support of CDPH, CDC, and OD2A for making this work possible as we collaborate with healthcare providers to improve opioid and chronic pain-related care through innovative training and technical assistance services. And you should see our link to the website in the chat. Next slide. We have a small but mighty team. We wanted to flash all our faces on the PowerPoint. We are comprised of 3 clinician trainers and our administrative staff, and you will be hearing from Dr. Philip Coffin, our medical director, here shortly. Next slide. So it has been almost exactly 1 month now since the closure of these 29 LAGS pain clinics here in California. If you're on this webinar, you likely have caught wind of some of what's going on, but just to recap, the California Department of Healthcare Services temporarily suspended just select LAGS medical centers based on an investigation from the California Department of Justice and Division of Medi-Cal Fraud and Elder Abuse after allegations of patient harm and fraudulent billing came to light. Subsequently, the LAGS clinics voluntarily closed all their sites, leaving many patients in the dark about what to do next for their pain management. California Department of Public Health and DHCS have acted extremely quickly, and kudos to them. But since there's a national shortage of pain management providers anyway in this country, It is anticipated that many patients will have difficulty finding new providers. So a lot of these patients, as we may assume, will end up in their primary care providers' offices to bridge the gap until they find a new pain management specialist. Next slide. We're hosting this webinar today to get the word out about what's going on and what providers can do, but also to introduce a new service we're offering to providers affected by these clinic closures. Since we know how complex this topic is, we know how daunting it can be to inherit patients as a provider. So the link will be in the chat to find a portal to sign up for one-on-one educational sessions with one of the 3 clinician trainers on our team. I want to emphasize that we don't have an agenda in these sessions. They're based on a needs assessment to determine how we can best support you as a provider to both maintain sanity and utilize the tools and best practices out there to keep your patients safe during this transition. We have the resources to provide this service for the next month, and we'll be in contact with as many people who sign up as we can. With that, I will hand the mic over to Dr. Coffin to jump into our content for today.
Good afternoon, everybody. So I am really happy to be speaking with you all today about this really critical topic. I am an internal medicine, infectious disease, and addiction medicine physician. I do a lot of research, I do this work, and I also do continue to do clinical care. So I do continue to inherit patients who are on opioids, and sometimes I may not think that they should be. So this is a common topic in my own practice, and I'm really happy to be talking about it today. Next slide. So the key messages that I'd like you to walk away with are, first, continuity of care is critical. Second, stopping opioids actually can be risky. Opioids aren't just risky themselves. When somebody has been on them a long time, stopping them carries risks. And then patient-centered care is what we're really looking for, but it can take a lot of time to develop. You can't always just step into patient-centered care. You have to get to know the patient. Good documentation is critical, not just for patient safety, but also for your own well-being. For example, if you feel that you need to continue opioids on somebody, you want to make sure you're documenting things well. And now, next, buprenorphine is much easier to provide now than it used to be. Next slide. So there's really 3 groups of patients that are described here. One is patients with acute pain, and we use opioids for short durations for patients with acute pain. That's on the right of your screen. On the left, you'll see chronic pain patients not currently receiving opioid therapy. And in general, we try to stay away from opioids, long-term opioids, for chronic, non-cancer, non-end-of-life pain. There are times when we need to use opioids in those circumstances. For example, if other therapies have been tried and failed and or are contraindicated, we might need to rely upon opioids. Or if somebody's using opioids intermittently and we're able to maintain that intermittent use pattern, those kinds of circumstances potentially. And then you've got this group in the middle, which is what we're talking about today, which is patients who are already on opioid therapy long-term. And in that circumstance, we're going to talk about the options, but it's not the same. These aren't the same people as patients who haven't been started on opioids. We know when patients haven't been started on opioids that if we randomize them to, let's say, ibuprofen versus opioids, oftentimes they do better on ibuprofen than opioids and have fewer harms. With the patients that have been on opioids for a long time, these are qualitatively different individuals. Their bodies are different, and the way they're going to respond to things is different. Next slide. So when that patient walks into your office, there's a few things that we recommend you do. The first is, if at all possible, talk about the patient with a former provider. This may mean calling them up on retirement in Hawaii at a golf course and trying to get a sense as to what they were doing with that patient. Were they escalating the opioid dose, in which case you talking about stopping opioids isn't going to fly very well? Were they decreasing the opioid dose already on a taper, in which case your discussion of a taper might be in line with what they anticipated? And then you want to complete baseline assessments. And this means usually taking a separate visit to talk about the, to do these assessments with the patient, because there's multiple assessments you're going to want to do really around pain, not just pain, but also function. That pain on a scale of 1 to 10, that's not enough in this circumstance. You want to get a little bit of sense of function and enjoyment in life. And then you want to establish expectations for opioid prescribing. You might, with this particular patient, decide that they were going up on the dose, even though you don't think they should be on it. So you're not going to just taper them and cut them off. You're going to continue them for the time being, but you want to be honest with the patient and tell them that, you know, I don't usually prescribe opioids for this indication, and I'm going to in this circumstance, but these are some of the expectations that I have. And then you want to start talking about opioid use disorder treatment early if it's appropriate. If this person has evidence of an opioid use disorder, or you have some suspicions, you want to raise the idea of the medications that are used in opioid use disorder, like buprenorphine, which we'll talk about later, early, because it can take patients a long time to come to terms with the idea that they may be dealing with a use disorder instead of what they feel is pain resulting in their need for opioid therapy. Next slide. So patient engagement. The first step in patient engagement is recognizing the barriers that you face, the environmental factors, the burnout, the limited time that you have. And, you know, on those environmental factors, recognizing that we're all a little bit worried about our licenses when we're prescribing opioids now. That's just the truth. The California Medical Board has done a bunch of investigations, and people are timid and scared to prescribe opioids. So when you're inheriting a patient on opioid therapy, one of your first things might be, I'm worried about prescribing opioids. I don't want to. And that can unfortunately result in a situation of a patient being abandoned or feeling abandoned at minimum in their care. And then the patient's stressors. So the patient comes in terrified that you're not going to provide them opioid therapy. And that really sets up a serious conflict, and recognizing that is really important. In addition, recognizing the stigma that that patient comes in with. That patient knows that asking for opioids is going to lead to a ton of stress on that visit. And so one of the things that you can do to try to lessen that stigma is watch the language that you use. We try not to say dirty urine, for example, on a urine drug screen. We say unexpected results. The urine isn't dirty or clean. It has unexpected results in it. The terms addict and abuse, we don't use in medicine anymore. Abuse has been replaced with problematic use or a use disorder. And addict, we try to use person first language, so person with a substance use disorder. Next slide. Don't forget your motivational interviewing techniques. I think we've all gotten some training in this, and it's invaluable. Open-ended questions, affirming people's experience, reflecting, summarizing. This is really critical to try to establish that relationship with the patient as quickly as possible. Next slide. Okay, so you think this patient's dose needs to be reduced, and you want to think about the pros and cons here. One of the big pros is that if you can successfully taper somebody's opioid dose with chronic pain, most of the time it actually results in similar pain or even improved pain after a successful taper. But the key there is the successful taper. So how do you get to a successful taper? That's really complicated, and we're going to talk about that. There are a lot of tapers that have resulted in unfortunate outcomes. And the first thing we're going to talk about is some of the risks associated with tapering opioids. First thing to recognize is that patients who have been on opioids long-term have neuroplastic changes And they can actually experience heightened pain sensitivity, decreased function, psychological distress. And when opioids are pulled away, their brain sometimes can't adapt to that. It can be a radical change on their body. The next thing that we've demonstrated with some of our local research in San Francisco was that when opioids are discontinued, it actually increases the use of opioids obtained on the street. And with increasing fentanyl available, we know that even if somebody is prescribed opioids and let's say they're stopped because of some aberrant behaviors, and then they have an increased likelihood of going on to use street opioids, maybe exposed to fentanyl, may actually have an increased risk of overdose mortality in that context. So the health of that patient may actually get worse with discontinuation of opioids. Next slide. We also know from Vermont that patients who have had opioid discontinuation are more likely to have emergency department visits and hospitalizations for opioid-related reasons. And from a very large study in the VA, patients who were discontinued from opioids had a higher risk of fatal overdose and fatal suicide after opioids were stopped. And what's interesting here is the risk was greater the longer the person had been on opioid therapy. This is really important to recognize. And there are other data from Seattle that with similar findings, but it's really, this is really the crux of it. The longer somebody's been on opioids, the harder it is to transition them off without causing more additional problems. Next slide. So based on those data and some other data, the FDA and the CDC both strongly advised that the CDC guidelines on opioid prescribing not be misinterpreted. They have been misinterpreted to mean that everyone should be on below a certain dose of opioids. Those CDC guidelines, and I was actually part of the committee that involved in those guidelines, they were intended for opioid naive patients. So if you're going up on a dose, that 50 and 90 morphine milligram equivalent cutoffs in the CDC guidelines, those were intended for escalating opioid dose among people who are being started on opioids. It was never intended to be implied that somebody who's been on 400 milligrams of morphine for 25 years needs to come down below 90, or certainly not below 90 in a short period of time. In addition, the California Department of Public Health has issued a letter a couple of years ago, really trying to emphasize the need to continue to care for these patients, to and ensure the continuity of care and not abruptly change opioid doses. Next slide. So we talk about shared decision-making for opioid therapy. And this is, I'm gonna be honest, this is a challenge. And there are times when I can't achieve this with a patient because I've failed at this, but it's really important to try. And the first step is to ask the patient about what benefits they're getting from opioids and what risks they perceive. So they may identify mostly benefits for them. And you can discuss some of the potential risks. So if they were on opioids for osteoarthritis of the knee and they had a knee replacement and they're still on opioids, then there might be some other reasons why they're still on opioid therapy. If they're having really no evidence of improvement in pain or function, then that might be one of the risks or problems with their opioid therapy. If they're on a very high dose, then that's something that definitely comes with risks. If they're on other risky medications like benzodiazepines, oftentimes providers say, you know, I'm not comfortable prescribing these two classes of medications together. So we might need to address one of them, and addressing one and giving the patient the autonomy to choose which one might be a useful approach. Adverse effects don't just include overdose and death, but they include constipation, reduced libido, other things that the patient may not recognize as being due to the opioid therapy. The patient may have worsening comorbidities. They may have developed sleep apnea. Their COPD may have worsened. They may now have some cardiac disease, things that may put them at higher risk for bad outcomes with opioids. And then finally, they may have an active opioid use disorder, which we'll discuss on several fronts. Next slide. So you want to develop that plan with the patient once you've addressed these risks and benefits. You might want to taper opioids because I want to keep the patient safe, right? The patient is afraid their pain's going to get worse. They want to continue opioids. So the third option in there is transitioning to medications for opioid use disorder. The way that you communicate with the patient is really at the crux of this. You always want to validate the patient's pain and their experience. Pain is a subjective phenomenon. A pain expert we work with says that patients sometimes ask, are you saying this pain is all in my head? And she says, yes, this pain is all in your head, because pain is a cortical phenomenon of the brain. And it is really important to recognize that and validate the patient's experience. Recognize the power dynamics. You're the one in control. You control access to something that this patient desperately wants. And if you don't recognize that the amount of power you have, if you feel that you're being victimized by a patient, for example, then it's going to be difficult to find that common ground. Empower the patient to participate in the treatment planning. This is really key. As we know this from motivational interviewing. If you can get somebody to feel that something is their decision, they're much more able to adapt to it. Don't judge, be flexible, and be ready for emotions. Next slide. Next slide. So finally, you want to address some of the issues that the patient may be experiencing. For example, maybe this is a patient whose partner at home takes their opioids and uses them or sells them. And this patient may be at risk for violence at home if they don't show up with opioids. Maybe this patient has sold some of their opioids to pay for housing. Maybe they're marginally housed, and to stay housed, they've been selling some of their opioids to pay for housing. This in no way means you should continue opioids so a patient can sell them to pay for housing. But it does mean that it's really important that you know what's going on, so that perhaps you need to connect them with additional housing resources so that they don't end up on the street because you tapered or discontinued their opioid therapy. In addition to that, you want to address their pain with additional pain management strategies, and there's a whole bunch of options for that, both medications and non-medication strategies. You want to make sure they're linked up with mental health services, social support. Usually, a taper should almost never result in withdrawal symptoms, but you might want to give them withdrawal medications in case they're scared of those symptoms. And then you want to discuss changes in tolerance and overdose risk. So as you're tapering opioids, that person gets at a higher risk for overdose because they might resume their prior dose at some point due to severe pain or withdrawal symptoms, in which case they'd be at very high risk for overdose. Next slide. So you've decided you're going to taper. You've spent some time to get to know the patient's stressors, their needs, and their pain. You're not going to rush and start a taper immediately. It's really important to get patient buy-in. And then you're going to individualize the taper plan. You're going to discuss the risks of tapering. You're going to involve the patient in selecting the taper speed, frequency of dose reduction. So which med first? Is it the benzodiazepine? Is it the opioid? Is it the morphine or the oxycodone? How fast are you going to go? How often are you going to come back? Give them power to make those decisions. And withdrawal medications if they're scared and they feel they need them, but really you shouldn't be tapering so quickly that somebody goes into withdrawal. Next slide. Tapers should be slow, and they might take years. This is hard for, let's say, a healthcare insurance company to recognize when you're trying to get another prior authorization for this high dose of morphine that the patient's been on for years, and you're tapering it. And 2 years later, you're still tapering them. And that actually makes a lot of sense medically and for the welfare of the patient, but it's really hard for the insurance company to understand. These abrupt tapers are dangerous. And it's important to recognize that each patient has a different successful taper. You might, if you have somebody who's been on 400 milligrams for 30 years, you know what? If you get them down to 300 or 200 milligrams, that is a huge success. That's half as many opioids on the street. But you're not going to get any plaudits from the insurance company who says you're still above our magic 90 number. Next slide. Okay, so while you're dealing with this, it's really important to think about documentation. And this is how you can alleviate a lot of your concerns. The vast majority of investigations of providers around opioid prescribing have concluded with, let's say, a complaint or withdrawal of a license. Almost all of these have been based upon insufficient documentation. So if you do the documentation and you justify, you put in your rationales for continuing opioids on this patient, maybe it's because you're concerned about the overdose risk. You're concerned about utilization of of emergency department and hospitalizations that are associated with opioid discontinuations. Those might be some of your justifications. In this case, this is we have some suggested domains that you should cover in your documentation and a little bit of an example. So in this example, a 55-year-old man presented with pain and numbness in both hands and feet. Frankly, that's not a great indication for opioids, but this has been going on for a decade, and they've been on opioids for that length of time. The pain is severe. They have some erosions in their hands, a mildly elevated rheumatoid factor, but really nothing to really justify high dose opioids. Next slide. Currently, their pain, we describe using a PEG-3. This is a much better than that pain score. What's your pain on a scale of 1 to 10? And the patient walks in looking good and smiling and says their pain's a 12, and you don't believe them, right? So it's hard to believe. The PEG-3 asks average pain in the past week, which gives you a better sense. Maybe their pain is only at night. Maybe they have lower back pain, and when they lie in bed, they're in absolute agony. But when they come to clinic, they're fine. So you get their average pain over the past week, and it also gives you how that interferes with their enjoyment of life and how it interferes with their activity or function. So those kinds of things are really useful. And then you get into a little bit of the history of therapy. So this patient was on oxycodone 30 milligrams 4 times a day, and it was reduced by about 20% a couple of months prior to this visit. The patient says he didn't want opioids, but now he really needs them. Next slide. So you want to do a little bit of a risk factor assessment. In this case, the opioid risk tool was utilized. I don't love this tool, but it is a relatively easy tool to utilize. The patient was at intermediate risk, primarily for a history of remote methamphetamine use and some alcohol consumption, as well as a diagnosis of schizophrenia. The patient is on antipsychotic medications, which is one of the risk factors for developing a problem with prescribed opioids. However, this patient screened out of having an opioid use disorder. The DSM-5 is invaluable, and we'll go through that in a minute. This patient had only one criterion for an opioid use disorder, which is a negative screen. If they had screened positive, then we would have started talking about buprenorphine probably in this visit. Next slide. The urine drug screen was as expected. Because they're of a higher risk, we would repeat this more frequently than annually, for example, every 3 months. There is a controlled substance agreement on record. There aren't data to support these, but they are kind of standard of care that you have some kind of agreement, whether it is just documented well in the chart and you've given some paper describing controlled substances to the patient, or you've formally done this, what's often called a pain agreement, but it's really not about pain, it's about controlled substances. So having one of those is useful. And then checking the controlled substance monitoring program, the CURES system, is really important and mandated at this point. And you just want to note that there's nothing unexpected. And then it's good to have the patient have naloxone at home, and ideally keep it with the opioids in case they're accessed by somebody else, for example. Next slide. So in this case, the plan was to continue to follow the risk and the DSM-5 score, to get some new imaging to see if there's been progression of disease in the hands, continue the current dose of opioids with frequent urine drug screening. And then the rationale for this, and this is what I think is really important for protecting your ability to care for patients that may be higher risk. So you note that the patient's been on opioids for a long time and was recently tapered fairly substantially. And although the indication's weak, there are recent data that discontinuing opioids can result in significant negative health outcomes. And there's no urgent need to do that in this patient, as they don't have a use disorder going on. And that you are a new provider for the patient, and you need to get to know the patient better before considering significant changes. Next slide. And I will pass this on to Rebecca.
And actually, while we're transitioning to talking about patients who have opioid use disorders and buprenorphine, I realized that we had a poll in my intro that I forgot to launch. We do want to connect with all of you and see how you have been impacted by what's happening with these LAGS clinics closures. So we are going to launch the poll. Maybe it'll give you a chance to do something different, not focus on the slide. We want to know, have any of you received patient transfers from LAGS clinics? Yes or no? And you can select any of the following that apply to you. What are your concerns about inheriting patients on opioids? So go ahead and we'll give you 20 seconds or so to fill these out. Thank you for your responses, especially after Dr. Coffin's talk. I imagine a lot of these themes are percolating. So I'll just give it another 5 seconds for those of you who have not responded, and then I'll end the poll. All right. So I'm going to share the results. It looks like most folks on the webinar have not received patient transfers, though we have about 32 people who we're assuming are providers here on the call who have. And concerns about inheriting patients on opioids, I think this spread just goes to show that the concerns are many, from I'm not a pain management expert, my license could be at risk, and the top runner here being asked to refill high doses of prescription opioids without the patient history or context. So do take a look in the chat. We have the documentation template for how to help fill out that context and get some patient history down on paper. Really, these relationships with patients take a lot of time. So if we're documenting adequately, we can give ourselves that time to work with the patient and get to know what they really need. All right, so back to the slides. If you do suspect that a patient you're seeing might have an opioid use disorder, going through the DSM-5 criteria is the best way to get a finger on the pulse for what's happening in the patient's life and what next steps to take as the provider or team member. There are screening tools out there using the DSM-5, but we've also put together this hopefully helpful graphic to categorize the different aspects of a use disorder. Use patterns, for instance, when a patient is unable to stop or cut down their use of an opioid, continued use even when the patient experiences health or interpersonal problems, for instance, from their opioids. And the final category is drug effects, like tolerance or withdrawal. And note that these do not get counted towards the total point score unless the opioid that the patient is taking is not prescribed by their provider. Determining whether a patient has a mild, moderate, or severe use disorder by tallying the points can help you identify what the next steps should be. For instance, we really want to prioritize medications if the patient has a moderate or a severe opioid use disorder. Next slide. Because the reality is, unfortunately, nearly 80% of people with an opioid use disorder do not get medications like buprenorphine or methadone that they need to treat their opioid use disorder, which I'll call OUD from here on for short. I want to remind us here that medication has the best evidence for treating OUD. This slide shows a massive seminal study done by Pierce et al. In the United Kingdom, showing that patients who only received a residential intervention for opioid dependence that did not include medication-based treatment had twice the risk of fatal overdose compared to patients who were on medications for opioid use disorder. The green bars are the patients who did not have meds, blue bars are patients who did have meds on board. And this drives the point home that if your patient has an opioid use disorder, it's essential to arrange for medication-based treatment rather than sending them to a residential facility or arranging for psychological support as a standalone. This is probably not news to most of you who are on this call that medications for OUD are the best way to keep a patient safe. Next slide. We're going to hone in on buprenorphine during the webinar, the remainder of the webinar, since it's a medication that can be prescribed by any licensed provider with the buprenorphine waiver in outpatient settings. However, I do want to give a shout out to methadone and extended release naltrexone, which also have evidence of improving outcomes for patients with OUD. And on our team, we like to use the analogy that just like in diabetes care, once a patient starts a medication, it is considered long-term therapy. And although decisions can be made to pause or reconsider the type of medication that's being prescribed, there are much better outcomes for patients who stay on these medications than people who take them for just a short time, especially since substance use disorders are considered chronic relapsing conditions. So just like it doesn't make sense to stop a patient's insulin when they're doing well, it doesn't make sense to stop a patient's meds for OUD, methadone, buprenorphine, ER, and naltrexone, just because the patient's doing well. And in the case of OUD, stopping a patient's treatment has been shown to increase the risk of overdose and return to substance use. Next slide. So we all got the good news back in April. Many of us have been waiting for this moment to have less barriers to providers prescribing buprenorphine. HHS, on the federal level, updated the practice guideline for the administration of buprenorphine for OUD. It is active now as of April that MDs, DOs, PAs, NPs, you can see the whole list here of eligible providers who have a state license and a DEA registration number, can now sign up and get their buprenorphine waiver without having to do the 8 to 24-hour training requirement that used to be in place. I, as a nurse practitioner, did a 24-hour training, and it's just really tough to find that time as a primary care provider in your already packed schedule. So we anticipate this will bring many more providers into the fold, hopefully with a dramatic increase in the number of patients receiving buprenorphine. Obviously, it's going to require a lot more provider education and support. And the caveat here is that this only applies if you're treating less than 30 patients. So if you want to treat up to 100 patients or even more than that, the requirement still exists to go through the certification training. There should be a link in the chat as well to sign up for the Data 2000 waiver to prescribe buprenorphine. Please spread the word to your colleagues. Next slide. So why is buprenorphine such a great option for patients? Buprenorphine is a partial opioid agonist, meaning that it acts on certain opioid receptors in the brain, but to a much lesser degree than a full agonist, like your morphine, your oxycodone, your heroin. So it provides potent relief still from pain, cravings, and opioid withdrawal symptoms without the respiratory depression and euphoria that we see with other opioids. It has a slow rate of dissociation from the mu opioid receptor where it binds, producing a prolonged duration of action compared to other opioids. We also like that. Deaths due to buprenorphine are rare and generally involve multiple medications. Overall, it is a much safer opioid than the full opioid agonist. And on the next slide is a graphic to sort of demonstrate the difference between partial agonists, full agonists, and also illustrate the phenomenon of precipitated withdrawal. So let's just say the little orange hexagons here are oxycodone, heroin, that patients could either be prescribed or not prescribed. These are the full agonists that I was referring to, which are the majority of prescription opioids, because obviously we want full activity for pain management purposes at the receptor. The little blue folks are buprenorphine, the partial agonists, which displace the full agonist from the opioid receptor because they bind so tightly. But then they only partially activate that receptor, which you can see by the receptor looking sort of like a glass half full. Precipitated withdrawal is the phenomenon that happens because the brain and receptors are so used to being fully activated. So now they're only partially activated by buprenorphine, and buprenorphine taking over those receptors results in a withdrawal experience for some patients. Next slide. Here's some more of the safety features of buprenorphine. We call it the ceiling effect, mainly that helps reduce the risk for misuse and diversion, less risk of respiratory depression, overdose, and it has the unique ability to control or reduce craving and withdrawal without the euphoria of a full agonist. This can help providers who are frustrated, quite honestly, with prescribing full agonists and being concerned about patients' overdose risk and higher diversion risk to feel like there's another option to keep their patients safer. And a lot of folks have questions about why buprenorphine has to be co-formulated with naloxone. The bottom line is that naloxone is not active, and therefore there's no clinical effect from the, let's say, the sublingual or the film formulations, unless those formulations are tampered with in a way that they're broken down to be injected. So the bioavailability of naloxone increases when buprenorphine and naloxone co-formulated are injected, and that result antagonist effect makes the drug less desirable for people who inject drugs. Next slide. On the topic of safety still, the FDA put out a safety announcement in 2017 cautioning providers from withholding medications for OUD from patients who also have benzodiazepines or other sedatives on board. The bottom line here is that it's much safer for a patient to be on a partial agonist like buprenorphine, which has that ceiling effect of respiratory depression, remember, while on a benzodiazepine compared to being on a full agonist like morphine, which does put them at greater risk for respiratory depression. Recent studies have shown that although there's an increased risk of non-fatal drug-related poisoning associated with benzodiazepine treatment in patients with OUD, this risk is mitigated by buprenorphine treatment. Next slide. Buprenorphine actually does really well for patients who have comorbid pain along with OUD as well. This study briefly was an oldie but goodie, showing that through a retrospective chart analysis, a reduction in pain scores and improvement in quality of life scores after 2 months of sublingual buprenorphine compared to other full agonists. And a tip for patients with chronic pain is to split up the dosing of buprenorphine into BID or TID dosing 2 or 3 times a day to keep the patient's pain at bay. Next slide. This slide runs through the different formulations that are open for providers to prescribe buprenorphine. Sublingual tablets or films of the co-formulated bup with naloxone can be prescribed, though formulations without naloxone can be considered if the patient tolerates them better. Buprenorphine is buprenorphine, and remember that naloxone is not active in the co-formulated product. A huge education piece that should be emphasized with every patient is to make sure not to swallow the sublingual tablets or films, but they need to be dissolved in the cheek or under the tongue all the way in order to be completely active. And the monthly subcutaneous injection of buprenorphine, brand name Sublocade, is becoming increasingly popular for patients who don't want to have to deal with daily dosing and want to be on long-term therapy. Next slide. So how to start buprenorphine. We won't go in depth here about how to safely start patients on bup, either in your clinic or from the patient's home, but rather want to give a brief overview of buprenorphine induction, which is what it's historically been called. We're advocating to change, we, along with many others in the field actually, are advocating to change the term to buprenorphine initiation, which is a less confusing term. Initiation algorithms are abundant. This is the one that we have in our guidebook. They live online. Various facilities have their own protocols. Please reach out to us. We're happy to provide some if you're interested. The primer I'd like to give today is that mainly patients who have used opioids before are often familiar and even experts at managing their own withdrawal symptoms. And buprenorphine is not going to work unless a patient's in withdrawal already a little bit. So when starting or initiating buprenorphine, you should counsel patients to wait at least 12 hours after their last dose of heroin or most other opioids, with some exceptions. And when they take their first dose of buprenorphine, they should have at least one objective sign of withdrawal, like shivering, a runny nose. Subjective signs can be in there too, like anxiety. A typical first dose is 4 milligrams, and then the patient can add 4 milligrams more every 1 to 2 hours until the withdrawal symptoms go away. First day, typically, you're going to have somebody take up to 12 milligrams. Subsequent days, a max of 16 milligrams. Next slide. A new trend in opioid initiation that we just want to alert folks to, many people may already be using this on the call, is something called overlap initiation or microdosing. And the whole point here of overlapping is that you don't throw a patient into precipitated withdrawal by rapidly displacing those full agonists that they've been prescribed with buprenorphine. The net effect of doing so involves some withdrawal because buprenorphine doesn't activate those receptors to the same extent. So if you do gradually displace the full agonists over a period of days, let's say by adding 0.5 milligrams of buprenorphine, but continuing the full agonist, the withdrawal effects will be much more manageable, if even observed at all, keeping the patient feeling okay, and ideally leaving them liking buprenorphine rather than associating it with the worst withdrawal experience of their lives. And this is a very common approach to buprenorphine initiation for patients who are using fentanyl. Next slide. Many of you will inherit patients or have inherited patients who are on buprenorphine as well. So this slide gives an orientation to what you want to consider in continuing their care. I won't go through everything on here. There's some tips for follow-up visits, how to incorporate urine drug screening, other mental health care. The takeaway point is that buprenorphine is an empowering medication. It gives patients control over their opioid use. It lowers their overdose risk. And I like to think of it as a team player. Makes providers more comfortable, makes patients feel better. And the caveat here that it just doesn't treat other substance use disorders. So don't forget if the patient is using alcohol, methamphetamine, benzodiazepines, to come up with a plan as well to address those use disorders in the future. Next slide. Due to the COVID-19 emergency, prescribing regulation has changed. So now clinicians with the buprenorphine waiver, even if it's a new buprenorphine waiver, can prescribe bup to new and existing patients with OUD via telehealth. And studies in the VA, San Francisco, and New York City have shown that this is a safe method of prescribing bup and can potentially increase access to care. Next slide. So to wrap up, back to our key messages from the beginning, we really want to emphasize that continuity of care for these patients you may be inheriting is critical. Stopping opioids can be risky. And I know when I started out in primary care practice, I stopped patients' opioids, and I threw a lot of patients under the bus because I didn't know what else to do. We know now that there are so many risks. So take your time to develop a plan with the patient. Document to cover your license and enable other providers to know what's going on with this patient if they see the patient for an urgent care visit or what have you. And buprenorphine is now much easier to provide. So get on the train, try out buprenorphine. And if we go to the next and last slide, as we think about lots of providers starting to try buprenorphine for their patients, we want to make a huge, quick plug for the California Substance Use Line for providers and any healthcare workers on teams working with inherited patients, or really any patient with a substance use disorder or issue. This service is staffed 24/7 by very experienced pharmacists and physicians from both the California Poison Control System and the National Clinician Consultation Center. Give them a call on a lunch break when you're having trouble with decision making with a patient. They are a phenomenal team that has coached many providers through buprenorphine initiation, what to do with opioid tapering, for instance. Their phone number is down here on the right, and the link should be in the chat. The next two slides are our references, and we will move on to the last slide if there are any questions. Thank you so much for hanging in there with our team, and there's lots of questions I recall from the Q&A. Philip, do you want to kick us off with Q&A?
Sure, let's hit the buprenorphine one since you're on that and you can follow up on those. So 2 buprenorphine questions for you. The first is up to 30 patients without any training. Is that for a year, month, or what period? I believe, if I recall this correctly, it's 30 patients being actively prescribed buprenorphine.
That's correct. So if a patient was to leave your practice, you could onboard another patient.
Exactly. Or if they went off buprenorphine, then you might end up prescribing to 60 patients in a year. It just depends on how things flow. The next one was the question about noting that some providers have been prescribing both buprenorphine and a full agonist opioid. Do you see that, and what's your experience with that?
So that's better than a patient being on just the full agonist. You're going to have a patient safer when they have that partial agonist on board because of the ceiling effect. That's not a long-term strategy. Typically, if you're sort of wiggling down their full agonist while increasing buprenorphine, or let's say a patient may have an acute pain need for some additional full agonist support, we definitely see it, but it should not be a long-term plan. The patient should not need the full agonist for pain support. There are other strategies like splitting up dosing or increasing dosing if the patient's not getting the full effect that they need for their pain.
Yeah, I think it can be a transition, like we said, with the overlap initiation approach. So another comment here was from the manager of clinical pharmacy services at HealthNet, noting that that LAGS members have been left without medication. It's taking weeks or longer to get to their PCPs, and some are refusing to prescribe opioids. Urgent care telehealth providers won't prescribe opioids, and members end up having to go to the emergency department for a refill and get a new referral to pain management and then wait around for an appointment. And this person is asking what we can do to bridge the gap so they go without medication and end up in the emergency department. I have to say this hurts to hear this. This is exactly what we were worried about. And providers and health systems really need to step forward on this. I know there is a lot of fear about the regulatory implications of prescribing opioids, but in this example, the pendulum has swung so far that we're refusing to provide needed care for patients, and that is frankly unacceptable for our healthcare system. We hope that some of the information that we provided on intake of these patients and documentation that can help providers and systems feel more protected and more able to take on patients like this in an emergency like what we're experiencing right now.
And just to say, it's helpful to put ourselves in the patient's shoes as well. This is not the patient's fault that they've been dropped from care. So really refusing to prescribe a medication for somebody who has received years, months, whatever it may be, of care from a provider who they trusted, the patient is going to go into withdrawal if they don't get those medications. So really use documentation, but consider at least refilling. And, you know, if it's more comfortable to bring the patient back in a week, 2 weeks to address more thoroughly their needs, you know, we don't want to leave these patients out to dry to go into withdrawal. They're going to have to go to the emergency room if they go into withdrawal. So it's a real conundrum, but we want to encourage a patient-centered approach to this situation.
Another comment was, what is your view of the statement that opioids should never be prescribed since other treatments have been shown to work better? There are circumstances in which opioids should be prescribed. For example, the studies that have demonstrated other therapies to be better than opioids have been among opioid naive individuals, not people who are on opioids already. So people who are on opioids already are qualitatively different. In addition, those studies were among people who didn't have contraindications to other therapies. So when you have gastrointestinal bleeds and shoddy kidneys, you might not be able to tolerate the high dose ibuprofen that works for a younger, healthier patient. And so opioids might end up being one of the last resort therapies that you have. So this idea that opioids are suddenly terrible is the pendulum having swung too far to the other side. And we need to have a little more equanimity in our interpretation of the data and the guidelines.
Philip, there's a couple questions from pharmacists about what pharmacists may be able to do to help bridge the gap here. Do you have any ideas on that front? We've worked with fabulous pharmacist teams that are totally invaluable in working with providers. So harnessing pharmacists is crucial. Any comments there?
Yeah, I think it's always a good idea. I know some pharmacists are reaching out to providers and discussing situations with providers. I think that is really helpful. Commenting on reaching out to a patient's primary care provider and saying, this patient has been on 100 morphine equivalents for 10 years and suddenly they don't have a refill, they're going to be in a crisis situation. Maybe that would help light a fire to the primary care provider to manage the situation and not be scared away from it. There was also the question about opioids and benzodiazepines. That is always tricky. What we recommend in practice is using that as in general, we don't prescribe the two together. It's important to note that buprenorphine with benzodiazepines is much safer than a full agonist with benzodiazepines. Oftentimes, this is flagged. I'll get as an example, I had a patient who was on benzodiazepines for a long time and very high dose opioids. I transitioned them to buprenorphine, and promptly the psychiatrists decided that we don't prescribe benzos with opioids and cut off their benzodiazepines and put them into a psychiatric crisis. So it is important to recognize that buprenorphine has been demonstrated to be far safer with benzos than a full agonist opioid. So that transition to buprenorphine counts as getting rid of some of that dual drug risk. And then the taper, if you are going to be tapering somebody, it's important to give them the decision as to what gets tapered first. And so throwing that benzodiazepines into the mix can be helpful. Is buprenorphine covered in the Medi-Cal program? Yes, buprenorphine is covered. There are no prior authorizations for buprenorphine utilized for opioid use disorder in Medi-Cal.
And I just want to be conscientious of the time. There's a lot of questions that we haven't gotten to. We do want to release anybody, since it is 1 p.m. Please feel free to hop off the call, but we can stay on and try to answer at least a few more questions. Is that correct, team? Dr. Coffin? So if you do have to hop off, thank you so much for being here. We will make available all of the slides, the references included, the links that were put in the chat, and the live recording on our website. And so please, we'll follow up via email to make all of that available to everyone who registered.
So there was an interesting question. Are there any studies or data on outcomes in patients who are on chronic opioids, who are either continued on opioids by a new provider or just stopped? So there have been studies. Some people have tried to look at the transition between one provider and another, and that has not proven viable for various data and chart review reasons. However, there are plenty of studies about patients being discontinued, unknown whether it was by a new provider or by their former provider. But the data we presented on discontinuation of opioids is out there, and it's established, and it is really important to be aware of in that circumstance where you feel like you need to push the margins of your normal practice and continue somebody's opioid therapy.
I also wanted to get to, there was a question about calculations from for converting morphine milligram equivalents from, the example was given, oxycodone 15 milligrams daily to the buprenorphine dose. Buprenorphine conversions are not actually the way to establish final buprenorphine dose. So whereas you would calculate between, let's say, an oxycodone and a morphine, with buprenorphine, we arrive at the individualized patient dose based on the sort of wiggling of the dose compared to withdrawal symptoms and cravings. So we don't say, okay, the Oxy 15 means that the patient's going to arrive at an 8 milligram buprenorphine dose. We will work with the initiation protocols that are out there and gradually increase the buprenorphine until the patient's withdrawal symptoms and cravings are controlled. 16 milligrams is a very well-researched sort of landing dose, but some patients will require more. Some patients are well controlled with less. So it's a different strategy than just using conversion tables.
Another buprenorphine question, when do you use buprenorphine with naloxone versus alone? So either can be used for opioid use disorder treatment. The with naloxone formulation is generally recommended because it is it blocks any effects you might get if you were to inject the medication. However, some naloxone is also known to, for example, cause headaches in about 15% of patients. So I have had patients who can't tolerate the co-formulated product and do much better on the mono-formulated product. In addition, for pregnant women, we use the mono-formulated product because naloxone has no particular medical benefit in this circumstance, and we want to limit any medications that a pregnant woman is exposed to.
I just wanted to highlight some information that's come out in the Q&A about the process of getting the buprenorphine waiver, how long it takes. There was a question about that, and Jean Marsters, thank you so much for saying the process online is up to 45 days. I found that when I got mine quite a while ago, 5 years ago, it took a lot shorter time than that. And I believe that if you do contact SAMHSA, there's a way to start prescribing even earlier while the waiver is in process. So contact them if there's some situation at your clinic where you're going to need to start prescribing and you haven't gotten the waiver approval back yet. Thank you for that information. There was also a question about whether recently graduated providers are more comfortable with prescribing buprenorphine. I think the answer to that is yes, because there is much better, well, at least in our area where we are in the Bay Area, medical and nursing school curricula have now adapted to include buprenorphine waiver training and coursework during the time of training. And we're trying to get these providers experience before they even graduate and get out there in the field, which was not the case for me. I imagine not the case for most of us. So new providers are really great teammates in this endeavor to get more patients on medications for opioid use disorder. Any final questions, Philip, that we missed? There were a lot of questions that came in right at the end, so our apologies if we didn't quite get to everyone's questions. Any final ones that you see, Philip?
No, I think we're in pretty good shape. There are several more questions, but I hope we've gotten to the main topics. I want to thank everybody for joining us today, and please do feel free to reach out to us. The information is on the website.
Thank you, everyone. And maybe Claire, should we close the webinar now? Thank you.